We'll make a start. Hi, everyone. Welcome to today's NCRED webinar. My name is Lucy, and I'm the Knowledge Translation Lead here at NCRED. Um, Before we begin, I'd just like to acknowledge the traditional owners of the lands that we're all on. Today, I'm on Darawal country. I'd like to pay my respect to elders past and present, and also acknowledge that sovereignty was never ceded. This always was and always will be Aboriginal land. I'd also like to acknowledge the importance of the lived and living experience perspectives, which we'll hear from a bit today, and their importance in research, particularly around alcohol and other drugs. So thank you for joining us. Today we will have a presentation from Dr. Krista Seefried on the preliminary findings of a systematic review of outcomes and measures used in randomised controlled trials of pharmacotherapies for methamphetamine dependence. We then have a pre-recorded response from Shanae Roberts, who's the National Advocacy Coordinator at the South African Network of People Who Use Drugs. We would have really loved to have Shanae come and talk live, but I think it's about the middle of the night in Cape Town right now, so wasn't quite so appropriate for that. And then we're going to have a panel discussion, which is sort of going to be the bulk of the session today, featuring people from lived and living experience, talking about their perspectives on what really sort of matters in clinical trial outcomes. Yeah, so hopefully it's going to be a really good session. We'll hopefully learn a lot. But yes, so I will introduce Krista first. So Dr. Krista Seefried is the Clinical Research Lead and Deputy Director at NCRED, a Senior Lecturer at UNSW's NDARC, and a clinician at St Vincent's Hospital, Sydney. She leads clinical research and trials focused on reducing harms from substance use, with expertise spanning HIV, infectious diseases, and public health, and a strong focus on improving treatment outcomes for people experiencing methamphetamine dependence. So, Krista's presenting on outcomes and measures in trials of medications for methamphetamine use disorder. Thank you.
Yes. Okay. So thank you, Lucy. I'm happy to introduce the wider discussion today with just a very brief overview of data pertaining to the topic of outcomes and measures in trials for medications of methamphetamine use disorder. Next slide. Sorry, Lucy. I promise there aren't many slides, so we won't have a lot of this. I just wanted to echo Lucy in acknowledging the lands we're meeting on today. For me, this is Bijigal land, and I'd also like to acknowledge the commitment of people with lived and living experience who have informed, worked on, and contributed to this and all of NCRED's work, especially foregrounding the upcoming panel session. Next slide, please. This is just noting my declarations here, my employment, and some research funding. So just going to start really briefly on treatments and the background really quickly onto the next slide. Just contextualizing today's talk, it's worth noting that when we're assessing the principal drug of concern recorded for people accessing treatment or services, there's a clear demand for methamphetamine treatment. The most recent data indicate that after a small dip during COVID, both treatment and withdrawal episodes have increased in the last few years. However, unlike other drugs of dependence, in terms of pharmacotherapies, to date, there has only been weak evidence of effect demonstrated by single or small trials of individual interventions. And so first-line treatment at the moment is generally psychosocial therapy, such as CBT, motivational interviewing, or ACT. So how do we come up with the evidence for pharmacotherapies? If we just skip over to the next slide, we're just going to discuss really, really briefly how this evidence is generated. I just wanted to review how clinical trials are implemented. So the scope of the present webinar is outcomes and measures in clinical trials, and trial design and methodology are not the focus of today's webinar. So I just wanted to very briefly recap randomized controlled trials, or RCTs. So RCTs are generally conducted as either a comparison between two active interventions, and in today's data, we're focusing on medications, or one active medication and a placebo. In both instances, participants are assessed to determine if they're eligible based on predetermined criteria, and once they're enrolled, they're provided with either the active medication or the alternate placebo, generally matched and provided randomly. If we just skip to the next slide, when we talk about randomization, we're essentially referring to a process whereby everyone who is enrolled in the trial is assigned randomly to either of the two groups previously mentioned. So either the active medication or the comparison group, and this should result in two balanced groups of participants. So if we flip to the next slide, which is back to the previous diagram, all participants then receive the medication they're allocated to, so the active or the placebo or the active or the intervention. That's a different intervention to the active one under testing. And typically neither they nor their clinical team are aware of which group they're in. This is called blinding. All participants then complete the same measures of the predefined outcomes to assess for any changes. These are then compared between the two groups to see if there were differences between those who received the active intervention, the one that we're testing, or those who received the comparator. And so if we go to the next slide, we can see that outcomes are predetermined during the design of the trial, and they're the main focus of the webinar discussion today. So the primary outcome is the outcome that is selected to reflect the main research question or hypothesis of the trial. So for example, if you were asking, are participants who receive the active intervention more likely to reduce their methamphetamine use than those who receive the comparator? Most trials also assess several secondary outcomes, and these are really important as well, but they're not the ones that are selected to measure the success, so-called, of the intervention. So if we skip to the next slide, when we discuss outcomes, we really mean the response to the intervention. And an outcome measure is the tool method to quantify or measure the outcome of interest. So for example, if the outcome of interest was methamphetamine craving, the outcome measure might be a scale from 0 to 100 that's used in a trial. Trials are typically defined with endpoints, and researchers generally use statistics to predetermine a significant level of difference between the two groups, the one receiving the active intervention and the one receiving the placebo or the alternate intervention, to be able to determine whether an intervention was effective. So if we skip to the next slide, it's in this context of designing clinical research that thought goes into the selection of those outcomes. So the outcomes should be predetermined, they should be clearly defined and match the question the trial is attempting to answer. Outcome measures should be validated, and ideally, they're informed by the people who will benefit from the research. There's often quantitative measures, for example, of treatment efficacy, and there are also patient-reported outcome measures, and both of these are important. So, for example, if a treatment is effective but not tolerated, it's a key limitation to progressing any further scale up of that intervention. There are also contextual factors that are important when selecting outcomes for a trial. So for example, I've put here a reference to the US FDA. This is the governing body responsible for assessing new medications and medication approvals for distinct indications in the US. And they have a document outlining current recommendations regarding clinical trial design, including outcomes and measures for the development of drugs to support indications for treatment of stimulant use disorders. So this guidance is currently in a draft. It's been in a draft for a couple of years, which is probably symptomatic of the broader context of health governance at the moment. But it should be noted that in the context of developing a trial, that the researchers who are designing the trial intend for future application to the FDA for approval, researchers will be looking at documents like these to anticipate what the FDA would be looking for, particularly in the international context where the FDA is seen as having set a high bar. So oftentimes FDA approvals then filter out to other countries as well. So if we go to the next slide, we can see some work that our group is presently doing. Recently, we've been reviewing the literature to assess the outcomes and outcome measures used in 58 clinical trials that assessed pharmacotherapies for methamphetamine use disorder. It's sort of launched from a previous systematic review that we did. However, in this new update, we still find that the most common primary outcome is abstinence from methamphetamine. And this is measured in very disparate ways. So, for example, you have some studies that quantify a weekly proportion of stimulant-free urine drug screens. Then you have others that do an overall proportion of stimulant-free urine drug screens. You have some that quantify abstinence as at least 2 urine drug screens in weeks 11 or 12, or maybe that's weeks 8 and 9 of the treatment that are negative for methamphetamine or amphetamine. But then they have different thresholds of permitted missing or positive urines. And then you have others who have quantified what they call methamphetamine use weeks. So there's this really disparate sort of picture of how even when we use a very singular outcome like abstinence, it's not always measured in a way that can be easily compared across trials. Another common outcome with these kind of trials is methamphetamine use. And so in recent Australian data, which is presented on the next slide, this is sort of an example of methamphetamine use being used as, rather than abstinence predefined, we're looking for changes in methamphetamine use or reduction in methamphetamine use. So in these two randomized controlled trials in the Australian context, the TINA trial and the LIMA trial, what was looked for was changes between the two groups, essentially in how much methamphetamine they used over a 28-day period. And so in the TINA trial, this was a statistically significant change with a mean difference between the two groups of 2.2 days of methamphetamine use. So the people who received mirtazapine in the final 28 days of assessment had 2.2 fewer days of methamphetamine use than the people who were taking the placebo. Similar results were found in the LIMA trial, but the LIMA trial was not statistically significant on that primary measure. And so that really launches us into the next discussion, which will start with our overseas presentation, but really just around what's statistically significant, what's clinically significant, what's meaningful for participants when we're determining outcomes, and how should we be considering outcomes and measures from a participant perspective in our trials. And I will sign off there because really, I think the next presentation and discussion is where the webinar is at. So I will go camera off now, if that's okay, Lucy.
Of course. Thank you, Krista. Thanks for that wonderful presentation of those preliminary findings. So yes, as we discussed, we now have a pre-recorded presentation from Shanae Roberts. The presentation is called Beyond Abstinence, What Success Looks Like for People Who Use Methamphetamine. And Shanae Roberts is the National Advocacy Coordinator at the South African Network of People Who Use Drugs and a powerful voice for human rights and harm reduction in South Africa. Drawing on her own lived experience of trauma, violence, and survival in Cape Town, she has transformed personal adversity into a platform for national advocacy, championing dignity, health, and justice for people who use drugs. Shanae is especially committed to advancing the rights of women who use drugs, confronting gender-based violence, and challenging the stigma and criminalization that drive exclusion. Her leadership is rooted in a simple but powerful principle: nothing about us without us. So we'll now play Shanae's video. Thank you.
Morning, everybody from South Africa. Sorry I wasn't able to do this presentation in person. I'm sorry, not in person, do it online. But as you know, there's a massive time difference between Australia and South Africa. Nevertheless, I was given the option to do a pre-recording. So yeah. My presentation basically looks at beyond abstinence, what success looks like for people who use methamphetamine. And this is coming from someone with lived experiences and my perspective on meaningful outcomes in the treatment and clinical trials. So, my name is Shanae Roberts. I am the National Advocacy Coordinator for the South African Network of People Who Use Drugs. And today I'm speaking not only as presenter, but as a woman with lived experience on stimulant use, particularly crystal meth, or as we know it in South Africa, Cape Town, TIC. When people talk about meth, they often talk about it in very simple terms. They talk about addiction, they talk about crime, they talk about failure, but very rarely do they speak about why people begin using in the first place. So just a bit about myself. I've lived through a lot of trauma from a very young age, including years of childhood abuse, the murder of someone I loved being murdered, as well as my two nephews who were burnt out in a home when a fire broke out. So these experiences have shaped who I am. And when I talk about meth use, I want people to understand that for many of us, it doesn't start with the drug, it starts with trauma. When stimulants came into my life, it isn't a choice to develop a substance use disorder. Methamphetamine became a way for me to survive. I felt like I only had two options. That was either in my life or find a way to numb the pain enough to keep going. It gave me energy when grief had drained me. It also helped me avoid memories that I was not ready to face. It helped keep me in a world that felt unbearable. And in many ways, it really did save my life at that point where I was in, at that point of my life, with all this trauma that I was trying to work through, or at least trying to forget. So now I want to speak a bit about harm reduction. Harm reduction is the approach that first treats a person with a substance use disorder like a human being. It doesn't just, the harm reduction approach is not just about fixing the person, right? It recognizes that a person deserves dignity, support, and care, even while they are still using drugs. And that is why this approach really matters to me. So when we talk about treatment outcomes, clinical trials, and measures of success, we need to remember that every statistic represents a real person, right? Harm reduction understands that success is not always abstinence. Sometimes success is simply staying alive long enough to find a safer path to go forward. Okay, so how success is usually measured. Before we talk about what success means from a lived experience perspective, it's important to understand how success is usually measured in clinical trials. In most research studies looking at treatments for meth dependence, success is often defined through a number of measurable outcomes. One of the most common measures is abstinence, whether a person has completely stopped using meth or for a certain period of time. Researchers often verify this using using biological testing, such as urine drug screens, to confirm whether someone has used methamphetamine during the study. Another measure is reduction in use, which looks at whether a person is using less frequently or in smaller amounts. Clinical trials may also measure retention in treatment, meaning whether participants remain engaged in the program or continue taking medication or attending therapy. Researchers sometimes also look at changes in clinical symptoms, such as reduction in cravings, improvement in mental health, or changes in dependency severity. And finally, success can also be measured through treatment adherence, which refers to how closely someone follows the treatment plan or medication protocols. These measures are important because they help researchers evaluate whether a treatment is having an effect. However, what I want to highlight is that these measures don't always capture what progress or success actually looks like for people who use methamphetamine in their life. So success is very different to someone doing a research or a study, or to someone actually living through the substance use disorder. And that's why lived experience becomes really important when shaping how we think about treatment outcomes. This slide highlights some of the limitations of using abstinence as the only measure of success. When abstinence is the primary outcome, it can overlook many meaningful forms of progress that people experience. Recovery is not always linear. People may move through periods of use, reduction and change, and reducing can still represent important changes or important progress. Improvement in mental health, relationship, housing, and daily stability can also happen before someone reaches abstinence. For many people, safety, support, and harm reduction are essential first steps before abstinence becomes a realistic goal. And importantly, for some individuals, the first measure of success is simply survival. Overall, this highlights why we need a broader person-centered outcomes that reflects what actually matters to people who use crystal meth. Abstinence may be one outcome, but it's not the only meaningful measure of progress. Okay, so this slide highlights the difference between how success is traditionally defined in clinical research and how people with lived or living experience may define success. On the left, there are outcomes that are commonly used in clinical trials. They are often focused on abstinence from methamphetamine, negative drug testing, the number of days without use, treatment completion, or reductions in relapse. In many studies, success is therefore defined primarily as stopping use entirely. However, when we speak with people who use methamphetamine, success can become much broader. For many people, success may include reducing the frequency or intensity of use, or feeling more in control of their relationships with methamphetamine. It can also mean that methamphetamine use is no longer interfering with important parts of their life. People often describe success in terms of improved mental health, reconnection with relationships, gaining stability in housing or work, and feeling hopeful about the future. This slide highlights another way of thinking about success, not just stopping use, but changing your relationship, or changing the relationship someone has with methamphetamine. For many people, progress can involve gaining greater control, where use feels more intentional and less overwhelming. It can also mean defining more balance, where meth use no longer interferes with important parts of their life, like relationships, responsibility, or personal well-being. Another important element is stability. This might include improvements in health, in mental health, reconnecting with others, or gaining more stability in areas and daily routines. So in this context, success can be understood as a greater control, improved balance, and a more stable life, even if abstinence has not yet been received. Intentional use. So I just want to use myself as an example when it comes to intentional use. I've used meth problematically for a number of years, but through harm reduction support groups, I was able to reduce significantly. Now I barely use, and when I do, I feel more in control, right? So I want to just highlight the word intentional use. So in the beginning of January, when my partner was shot and was hospitalized, during this time I was working 5 days a week, managing a team, traveling back and forth to the hospital, caring for my 3 boys, aged 4, 13, and 15. When my partner came home, I took on additional responsibilities of feeding him, washing him, dressing him, while still maintaining everything else that I needed to see to. So it was very overwhelming for me and very exhausting. This constant back and forth work, kids, all the things I needed to do without dropping the ball. And at that point of my life, I chose to use meth in a more controlled way, just to cope with the demands that life was giving me. Because I just needed a bit of energy, a bit of nudge just to get everything done. Yeah, so it really helped me stay focused, maintain energy, and be present without becoming overwhelmed by everything happening around me. I used early in the morning so I could still sleep at night. I kept my doses small to avoid building tolerance and set clear limits for myself, including a cutoff point. After this, including a cutoff point. After stopping, I managed the effects by taking supplements, staying hydrated to reduce fatigue and brain fog. So for me, it is that I consciously made a decision. I know more about myth and effects, so there is greater awareness. It no longer um, it no longer is a crutch for my trauma, but rather when I'm juggling too many balls and I can't afford to let anything drop, it will give me that bit of a push that I need just to manage things, and also ensure that I have a cut-off date. So I know, okay, I'll use from this period to this period, but I need to cut off at this period. And then just to maintain health after that, I'll make sure that I have the vitamins that I need, and also that I'm dehydrated, and also any supplements that will help me, because you often get brain fog after that. So, yeah. Okay, so this slide highlights why lived and living experience should play a key role in shaping research and clinical trials. Traditionally, many clinical trials have been designed without the direct input from people using drugs or meth, which can lead to outcomes that focus narrowly on abstinence. While abstinence can be an important goal for some people, it doesn't always capture the full range of meaningful changes that people experience in their lives. Many people with lived experience are Many people with lived experience are involved in research design. Oh, no, sorry. When people with lived experience are involved in research design, they can help identify outcomes that better reflect real life progress, such as reduced use, improved well-being, greater stability, meaningful control, reconnection. Yeah. Including these perspectives help ensure that research is more relevant, ethical, person-centered, and that the outcomes measured in trials actually reflect what matters most to the people, and the research is intended to support those people, the which is affected by the substance use disorder. I think ultimately, designing studies of people rather than only about them can lead to more important, more meaningful, and impactful research, which I think is very important when it comes to having a positive outcome to any research or any study. So this slide just speaks about my connections, how I've managed to keep my connections through the years, whether it was through my campaigns, supporting the people, through the Female Life campaigns, while I was doing outreach with the community, or even just keeping a connection with my broader family and my immediate family as well. Yeah. So thank you. That is that. Thank you, guys. And a big thank you to Liam Ankerson as well as Lucy Watson for giving me this great opportunity to speak about the importance of clinical trials in the lives of people actually affected by substance use disorder. And if there are any questions, I'm sure Dr. Ankerson or Lucy could email them to me and I would gladly respond. But thank you so much for having me on this platform, and take care.
Thank you, Shanae, for that really fantastic presentation. I'd now like to invite all of our panelists to turn their cameras on. We've prepared some questions for the panel, But we also, of course, welcome any questions from you in the audience. If you have any questions specifically about the research, the preliminary findings that Krista presented, do feel free to send them through. We will focus the panel discussion now on the sort of lived and living experience perspective. So questions about the research, we can take them and answer back via email. And same with Shanae. If you've got any questions for Shanae, you're more than welcome to email us and I can pass them along and get you an answer. The best email is info@ncred.org.au. So I'll just introduce our panelists. Okay, so we have Bo Justin, Zhao. Bo Justin is the team leader of ACON's chemsex peer support programs, leading the implementation of Method, which is a peer-led service supporting LGBTQ plus people who use methamphetamine in sexualized contexts. Beyond client-facing work, he contributes to programs, campaigns, research, and policy initiatives across Australia and internationally. Thanks, Bo Justin. We also have Angus Mason. Angus is an Aboriginal researcher and former peer support worker. His mob is Gomeroi, but he was born, raised, and lives on Awabakal country in the beautiful city of Newcastle. Angus is in the process of setting up his own business that will focus on providing research support and selling unique artworks, drawing on his lived experience of addiction and mental health to amplify his work. He is passionate about improving outcomes for Aboriginal people, reducing stigma, and getting consumers involved in meaningful ways in research. Thanks, Angus. And finally, we have Stephanie Raper. Stephanie Raper is currently a lived experience support worker at the Hamilton Centre in Victoria. Previously, Stephanie has worked as an HIV/AIDS advocate, chairing Positive Women Victoria. In her spare time, Steph is a proud Swiftie. So thank you all for joining us. Firstly, I just want to understand a little bit more about all of you. We've just heard from your bios, but tell us a bit more about yourself, where you're from, what you do for work or fun, and your relationship to lived and living experience of methamphetamine use and dependence. We'll start with Stephanie.
Hey, good afternoon. I was born and raised in Melbourne, Victoria. I'm very privileged enough to work for the Hamilton Centre as a lived experience worker through an organisation called Turning Point. I am officially 3 years and 1 day abstinent from drugs and alcohol. In no way, in saying that, and I feel like this is an important way to say, in no way do I judge anybody who is not, and we will expand on my thoughts about that later. Proud Swiftie, friendship bracelets, analysing lyrics and bonding with concert goers outside of the concert is me.
Thanks, Stephanie. Bo Justin.
Hello, hi everyone. I'm Bo Justin Shell from ACON. I think I sound a bit nasal today because I've got a cold, so apologies. But I've been working at ACON for more than 6 years, and Method is our chemsex peer support program. So at work, I do a lot of one-on-one client-facing peer support work, and also some group facilitation as well. My experience with methamphetamine, I think we should call it living experience. So I first started using meth when I was only 21 years old, and that's been, I think, a journey of 16 years now. It has changed a lot. I think there were times it was more towards the daily use, the kind of dependence kind of situation. But these days, when I say living experience, I think I use like two, 3 times a year, and that's done in a very planned way. Yeah.
Thanks, Bo Justin. Angus.
Hi everyone, can you hear me? Oh, perfect, awesome. I was having some problems before, so that's great to hear. Yeah, so my name's Angus. I love to dance. I love to catch Pokemon, and I love to go to live music. Love to go to concerts and festivals. So they're probably my 3 main passions at the moment. I've had a bit of a on again, off again relationship with methamphetamine over my life. So sometimes using, sometimes not. Yeah, that's about it from me for now.
Thanks, Angus. I love to hear someone that's into Pokemon. That's amazing.
Yeah.
All right. So the first question I have for everyone, we're talking a little bit about success today, and we're sort of using that word because research often frames measures and outcomes to demonstrate whether a trial worked, i.e., whether the trial was successful. So can you talk a bit about the concept of success when it comes to changing a relationship with methamphetamine? What would success look like for you or the people you work with? Or maybe you want to problematize that word entirely. Um, Maybe I'll start with Angus.
Thanks, Lucy. Yeah, sure. I'd love to say something about this. So for me, success would look like being able to maintain my fitness, being able to maintain my body weight and body fat percentage when I quit methamphetamine. So for me, if I was to quit using methamphetamine and I put on 20 kilos, for example, I wouldn't consider that success. I would consider that a great failure for myself. I think especially being part of the gay community, I think being fit and looking good is particularly important for a lot of gay men. And as we know, methamphetamine is quite popular amongst the gays. So I think, yeah, that needs to be taken into consideration as well, because methamphetamine is such a strong stimulant. A lot of people do end up getting into fitness when they're on it. So, um, yeah, just to consider how we can help somebody maintain their body fat percentage and their body weight if they do want to reduce in their use.
Stephanie, do you want to jump in?
I moving away from that black and white thinking. I think of words in terms of what's the opposite. The opposite to success, and Angus said it beautifully, is failure. And I don't see anybody who uses as a failure. I see it as a measure of coping, as a measure of dealing with life. For me, having been born with HIV, a measure of me overcoming addiction was not waking up resentful that I'm alive. And it's a hard fact of anything, above that is a cherry on the cake, right? Wanting to actually live and really believing I had a future meant that I didn't want to harm my present. So definitely moving away from the black and white. And in saying that, the opposite to clean is dirty. So if we start using this black and white language, who are we referring to as the opposite and why? Why? So very much waking up wanting and grateful to be alive is my outcome for sure.
Thanks, Stephanie. Yeah, I think Shanae talked a bit about survival as being the first measure of success as well. But Justin,
Yeah, Lucy. I think to me, success means a sense of control over decision making around drug use. Um, so this comes from, I guess, my personal experience, but also the work I've been doing. So often, I guess we are automatically told kind that we have to stop completely, and that's not always easy to do in the first go. And I think gradually understanding the deeper rooted causes for somebody's substance use and why does substance use make sense in that person's life can be a really good place to start. And yeah, I guess a sense of control is what's really important to me when it comes to success.
thanks, Bo Justin. I think jumping off that a little bit, Um, Krista sort of talked about at the end of her presentation those two trials where, there was 2.2 fewer days that, like, in some instances was statistically significant. But the question sort of remains, is that clinically significant? Do any of you have anything to sort of note about that, about what 2.2 days could look like in terms of significance for someone using methamphetamine? Anyone can jump into this one.
Yeah, I'd like to say about that. I think 2.2 days could make a massive difference in someone's life. I mean, when I can think back when I had really bad addiction and things were just not under control at all. Um, I would just, I would keep going and going and going until I would basically pass out in public. And that was terrible, frightening and embarrassing. So even if that 2.2 days is that, 2 days of rest that somebody needs so they're not passing out in public, that could be a great thing for someone.
I think, and my colleagues online will be laughing, context is important. If the strategy was to quit cold turkey and the only evidence was a reduction of 2.2 days, is very different to 2.2 days reduction where it's a 2-year strategy of doubling those days every time. So if you think about it in terms of what's the strategy for this person, 2.2 days could be fantastic and meaningful, and sleep and going to the doctor and making a phone call. It could be the difference between surviving and not having a soft place to land. And again, the narrow measures of outcome and the way that clinicians have to present data can be very jarring. And I'm hoping that there will be a better way to present this in the future. But I echo Angus, is like 2.2 days could be the difference, could be everything in terms of survival and best quality of life.
Thanks, everyone. Yeah, I think Shanae mentioned something in there about behind every statistic is a person, and so much of this research kind of has to measure in numbers and anonymized people and pure statistical data, but remembering that those 2 days could be huge for someone is I think so important, and that point about context and where it fits in someone's broader life as well. Um, I want to just touch a little bit on the concept of abstinence. We've sort of touched on that in Shanae's presentation and in Krista's, but it's often the key measure or a key measure in these sorts of clinical trials. But we've talked a little bit before. Spoiler alert, everyone. We've chatted in the past, but when we talked before, we talked about the relationship between abstinence and stigma and discrimination. So I wonder, maybe Stephanie, do you want to start us off on what you think the relationship between the concept of abstinence and stigma is?
It is huge. I come from a Narcotics Anonymous recovery. Having to announce that you are clean and you are one decision away from not being. And then you've got the blurred lines of drug replacement therapy, not considered to be clean. So you've got a community that's meant to be non-judgmental and supportive, and then you've still got these narrow lines of who is better or worse amongst the pack, counting days. There is so much more to it, and it just perpetuates the stigma and discrimination, even within peer support groups, judging another person in that group for not being clean or how they're getting clean is bizarre to me. And the language is really changing, but not as fast as we need to. And the clinical language matches that. It just matches everything that we believe, that I'm not clean, I'm not worthy, and I'm a failure. Because we talk in terms of success, being clean, being dirty, or failing. And there's nowhere really that is free from stigma and discrimination, particularly with meth use.
Bo, Justin, or Angus, would either of you like to add to that?
I think to me, this is sometimes a bit of a lateral violence kind of situation here. Like people who use drugs are put into this group as drug users, as if they all use drugs for the same reasons, for the same purposes. And then they kind of use abstinence as a way to evaluate someone's recovery journey or their worth or how they're doing. We're also basically ignoring the person behind their abstinence. And I think that sometimes can really disencourage people from, getting back on their feet or seek support or even invest more in their recovery.
Thanks, Justin. I think that actually kind of lends well to my next question, which is about the importance of clinical trials being able to tailor outcomes for different populations, to be able to take into account different cultures, patterns, or meanings of methamphetamine use. So can you talk a bit about that?
Yeah, so I think gay men use meth in a way that's uh, quite different to the rest of the public. The Yeah, so a lot of times, gay men's drug use is done in that sexualized context, and it is about pleasure. It is a bit of a social norm. Like have doing parties and group sex and this kind of thing. So that is kind of a social norm. It is also about, I guess, shame attached to sexuality and identity in a lot of ways. Um, so yeah, so if I guess if we were going to support gay men as a particular group with their meth use, what we also need to do is to kind of also work on like all the other things that's causing them to use drugs. So what I mean is how do we kind of support people to have a better relationship with their sex, with their sexuality, how do we support people to get a stronger sense of identity, almost having a better relationship with themselves? Can we support them to, I guess, build different coping, um, different ways to cope, their mental health and all that sort of stuff? So yeah, so I guess in the work that Method has been doing, uh, one thing that we found is often to kind of help someone reducing their drug use, we actually need to leave the drug use aside for a while and actually just understand how does meth use make sense in that person's life, and kind of tailor the support for that person.
Does anyone want to add anything to that?
Yeah, please. I just wanted to add on to what Bo Justin said. I definitely agree. Is that I think one of the ways that we can start supporting people better is just ask them what do they get up to when they're on it. Because I think everybody's got kind of their different thing. Um, so mine is I love to go out and catch a whole bunch of Pokemon on my phone. But, some people have got their thing. They like to go out and collect shiny rocks or whatever it is. So I think if we find out what it is that people are really interested in when they get on it, that could help us support people better too.
Yeah, I think that sort of dives into my next question as well, which, we're kind of talking a little bit about the need to see the whole person and understand the context and all of that sort of stuff. And I think what comes into that is things like holistic health outcomes and social outcomes. And so I wonder if any of you have any particular thoughts on what kind of holistic or social health outcomes could these clinical trials be measuring as well to sort of test success in a sense. And maybe I'll start with Stephanie.
I think in terms of females, the risky behaviours that can go on, the interpersonal violence and control that can happen when you add methamphetamine use to an already violent relationship. Are these women having wanted pregnancies? Are these women feeling safe in their own home? Have they got access to their children? Are really important questions that are tossed aside when you only see abstinence. For me, it was about my health, whether I was taking my antiretroviral medication, whether I was having risky sex when I was affected by the drug. All of these things need to be counted. And unfortunately, it's not as easy to do. Getting, GPs and sexual health clinics on board would be able to get more data across other than a tick or a cross to days abstinent.
Does anyone else want to add anything there? Oh, Justin?
My feeling is just because someone's abstinent from drug use, it doesn't mean they live a good quality of life. So that's one part of somebody's life. But so those 2.2 days of abstinence, I'm thinking, how can this person use this time for? Is it to actually build more meaningful social connections while they are taking a break from their drug use, or are they actually doing more kind of life admin kind of stuff where that can usually to be put aside. So this needs to be really individualized and kind of fit the person's reasons for changing their relationship with drugs.
Yeah, I think again for me it comes back to the weight and the body fat percentage thing. Like there's links between obesity and depression and also feeling tired as well. So when you put weight on, it can affect your mental health. It can make you feel more tired. Um, so if I put on a whole bunch of weight, I could potentially feel less healthy than when I was using. Um, Another thing for me is being able to make appointments and being able to carry through with activities that I've planned to do. So when things get real chaotic, I just can't make some of those appointments and follow through with social activities or events that I've planned. So if I can, tick everything off on my calendar, then I know that I'm at least going okay. Okay.
Yeah, that's great. Thank you. I think something that we've sort of spoken about is that concept of the sort of clinical trial world versus the real world, and how things still happen outside, or it might take some real amount of time to really change a routine around methamphetamine use, and so all of those sorts of things that happen along the way matter just as much, and measuring that is the tricky part. Thankfully, we're not the researchers, so they can figure that out. But I am conscious of the time. I thought maybe we might like to just end on a final question. Like we've largely talked about outcomes of trials. That's sort of been the focus of the presentation here. But just to kind of return ever so briefly to that research design aspect. Obviously, we need lived experience involved in the research design so that we can have the outcomes and measures that are meaningful to people with lived and living experience. So I wonder if any of you have any advice for researchers or policymakers that might be on the call who are thinking about designing clinical trials, funding clinical trials, particularly in the space around medications for methamphetamine use. What sort of advice would you give people in that space? And I'll start with Angus.
Thanks, Lucy. One of my pieces of advice would be to try and consider looking at longer term trials. I've noticed a lot of these trials that have been running around treating methamphetamine dependence has been quite short. A lot of them are 6 or 8 weeks. I think it's really difficult especially if you've got a really bad methamphetamine addiction, to get that under control in 6 weeks. So I'd encourage people to, if they can, start looking at running longer studies up to 6 months, even I would say would be an more appropriate time frame. And another thing I would encourage is to make sure that if you're going to set up a research trial like this, get a good consumer advisory group on board, get a good consumer researcher that can run that group, um, and it needs to be done in a way that's non-trivial, that's really meaningful to the research. You don't want your consumers to be sitting there moving pictures around on a page for your design pamphlet or something. You want them to be getting into the guts of the research, looking at the research questions, interacting with the consumers if possible, the participants if possible. So yeah, I just think consumer advisory groups, when they're done well, are completely invaluable to the research. So those are my two pieces of advice.
Thanks, Angus. Stephanie.
A lot of these trials are happening in detox centres and hospitals, and I cannot bring safety home more. If you are considering the environment you are taking the trial participant from, putting them in, and then returning them to, if the environment you're doing the testing does not have any activities, any access to outside exercise, proper nutrition, a comfortable bed, the outcome of the study is going to be affected. But more importantly, the participant is going to be suffering. In terms of, again, female health, are the female participants safe while doing this? Is this a risky environment where they could be potentially harmed? In terms of medical health, if something were to go wrong in these detox centres, for myself, perhaps an outbreak of an illness or something, are there specialists to take care of that? A lot of what Angus had to say about medical appointments often are lagged. So by the time participants come to the study into the detox centre, a lot of health needs to be addressed. The care of these the trial participants. And shout out to lived and living experience workers to have somebody there to talk to about it, because often the participants can't tell other people what's going on or what they're a part of and feel more isolated while doing it. And also echoing a point is longer trial periods to follow up, because 1 or 2 chance of success and failure in terms of abstinence is not statistically relevant towards the average time of 6 relapses per 10 years of recovery. So longer term trial studies and safety of the people doing it, making sure it is of value to their lives to be doing this for the future outcomes of people who want to detox and have better outcomes for themselves and their own goals. Thank you. Let's stop putting goals onto these participants and let them achieve their own.
Thanks, Stephanie. But Justin.
I'll be quick because I think Stephanie's said what I wanted to say, which is to allow participants to define their own goals and also provide counseling support or any kind of allied health support on the side with these trials as well. Yeah, I'll leave it there.
Thanks, Bo Justin, and thanks Stephanie and Angus as well. Thanks to Krista for her presentation. Thank you so much to Shanae for doing that recording for us. And thanks to everyone for coming. We are at time, so I'll leave it there. But if you do have any questions, I noticed there was a question in the chat about some PDF resources. If there's anything that you'd like, do send us an email at info@ncred.org.au. We can kind of compile up what we need. We can pass on questions to Shanae, to Krista. Whatever it is that you like, just shoot us an email. Our next webinar will be in late May, so keep your eye out on the mailing list for information about that one. And also there'll be a survey that comes through from Zoom. It'd be really great if you have the time to fill it out, just to let us know how we're doing and what we can do next. And we'll also send you the recording when it's ready as well. You can feel free to share that around. So thanks everyone, and thanks again to our panelists for a wonderful discussion. It was so important to have you. Thank you.
And thanks, Lucy, for hosting.
Thank you to co-panelists.